Well, this is the session Diagnosing Myositis, to be sure. Okay, well, my name is Marianne de Visser. I am a neurologist in Amsterdam, at the Amsterdam University Medical Center in the Netherlands. And I have been seeing patients with myositis for about 20 to 30 years. What I'm going to do is tell you about the different diseases, because not too long ago we only had 3 diseases: polymyositis, dermatomyositis, and an inclusion body myositis. And in the meantime, there have been developments with regard to the classification of myositis, and I'm going to tell you about the developments that have been made in the diagnosis. Now, you all have been diagnosed, so I hope that I can live up to your expectations. Because I'm not going to tell you apparently something very new, but maybe you can learn me something about what was done in your case. So this is what we see as myositis nowadays. We have dermatomyositis, it works. Dermatomyositis, and there are several types based on various auto-antibodies. I will touch upon that later. There is inclusion body myositis, and there is a huge group which is called polymyositis, but can be subdivided into 3 different types. A type which we call non-specific myositis, a type which we call necrotizing myopathy, and a type which we call anti-synthetase syndrome. And here I summarize all the particular features, the skin abnormalities in patients with dermatomyositis, as I said, the auto-antibodies, that you have to search for cancer if you're diagnosed with dermatomyositis, the peculiarities of the muscle biopsy, and that holds for all the different entities. But don't worry, I will elaborate on that during this talk. And this is what we have as diagnostic procedures. Obviously, it starts with talking to the patient, and we call that history taking. But it's nothing else than listening to the patients and asking them questions. Then in these cases, when we have taken the history, in about 60 to 70%, we have a certain clue about the diagnosis. And we're going to confirm that by doing the clinical examination. Then we have lab tests, and in myositis, the CK, the creatine kinase activity, is the most important one. Then there is the possibility of an EMG, and I must admit that in my hospital we hardly do an EMG because it does not contribute very much to all the other diagnostic procedures. Then there are muscle-specific and also muscle-associated antibodies, and I will come back to that during this talk. Muscle imaging by means of MRI has gotten a firm place within the diagnostic procedures. And finally, the muscle biopsy. With regard to symptoms, and as I said, we are starting with listening to the patient. So if a patient tells me, well, I'm not going to ask him, do you have a paresis of your legs or your arms? Because that is utterly nonsense for a patient. The patient complains to me about having difficulty getting up from a chair, of having difficulty hopping on a bus, or having difficulty brushing or washing her hair, or having difficulty with swallowing. Those are the complaints that the patient tells me, or if he or she doesn't, I have to specifically ask for. And these are the complaints that you expect to hear in polymyositis, because in polymyositis it's the muscles of the pelvis and the thighs, the muscles of the shoulder and the upper arms, but also the neck muscles and the throat muscles, which are usually affected. And it usually starts with the thigh muscles. Exceptionally, it can start with weakness of the shoulder girdle muscles. Well, the same holds true for weakness in dermatomyositis. But dermato means, as you all know, skin, which means that in addition also the skin has to be affected. Like here, the rash around the ears or the rash around the knuckles on the hands. And we also know that there is a form of dermatomyositis in which only the skin is affected and in which there is no muscle weakness. And that is called a myopathic dermatomyositis. A, which means without, myopathic, without muscle weakness. And finally, this is not a session especially about IBM, but I was asked to include IBM as well, because sometimes it's very difficult to distinguish IBM from polymyositis. Here also the thigh muscles and the pelvic girdle muscles are affected, so here too there can be difficulty with getting up a stair, getting up from a chair, hopping on the bus. But in contrast to polymyositis, the forearms are affected, which means that there are difficulty with the weakness, with the strength of the finger flexors, and also the pharyngeal muscles, the throat muscles, are affected in IBM. If we have a look at dermatomyositis, you see here various kinds of features. These are the most frequent abnormalities, with a rash around the eyes and on the cheeks. And you see here abnormalities which are called Gottron sign and Gottron papules, that is thickening of the skin. There is a type of dermatomyositis in which there are ulcers, usually at the fingertips, and in some of the dermatomyositis types there can be calcifications, and especially around bony parts as the elbows and the knees and the pelvis. By the way, if there are any questions or comments you would like to make, please interrupt me. Sure.
So the ulcers for the fingers, is that the typical mechanics hands?
No, that's different. Yeah. I'll come back to that later. I'm glad you mentioned this. And this is inclusion body myositis, and as I said, it can look like a polymyositis, especially in the beginning, when the finger flexes are as yet not affected. As you can see, this lady has difficulty getting up from her chair without using her hands. And she only had weakness of the thigh muscles at that time, and I followed her for years, and in due course her finger flexors were affected, and she also complained about swallowing difficulty. This is how eventually the upper legs will look. You see that they are wasted because there is a loss of muscle bulk, and you can also see that on an MRI. These are the same muscles, and white means that the part of the muscle has been replaced by fat. So this is normal, this is black muscle, but all these muscles, and especially the ones you see here, the thigh muscles, have been considerably replaced by fat. This is what I meant with the finger flexor weakness. This patient is trying to make a fist with both hands, and on the left side it's not possible at all, and on the right side just a little bit. And one of the peculiarities of IBM, in contrast to dermatomyositis and polymyositis, is that there is asymmetric involvement. You can see here that the right hand is just a little bit better as compared to the left hand. And finally, there can be what we call dysphagia, swallowing difficulties. Here you see esophagus in which a bolus of food is going downwards, and here it goes into the stomach. And the problem with IBM is that there is weakness of part of that organ, which means that the food does not easily pass, and sometimes people have the experience that it comes through their nose. I will show you a patient later who started with swallowing difficulty. I mentioned that CK, a protein that you can find in the blood and that indicates leakage if it is elevated from the muscle cells. The muscle cells are ill and then they leak the CK, and you can find that in the blood, and it can be very helpful. In necrotizing myopathy, it's usually very high, and with high we mean 100, 200, up to 500 times the normal value. But it can also be normal in dermatomyositis, for instance, and inclusion body myositis. So if a patient is suspected of myositis and you find a normal CK, you cannot discard it as not being a myositis. Yes, you had a question.
I have a normal CK.
You have a normal CK?
Yeah, and I was diagnosed with polymyositis. So.
Yeah, but then the question is, I showed you in the beginning that there are 3 kinds of polymyositis. One of them is the necrotizing myopathies, so it's not very likely that you have that kind of form. The other one is anti-synthetase myopathy, and I'm going to show you that has lots of additional symptoms. And the third one is the non-specific myositis, and it may well be that you are suffering from that one.
But they can be normal.
Sorry?
But the CK.
CK can be normal, yeah.
So, yeah, I have DM and my CK has always been
Be normal,
and
yeah.
my doctors didn't think that I had muscle involvement then, but I feel it. I know it's there.
I know.
Is there another way to?
No,
any other kind of
if you feel that there is muscle involvement, there is muscle involvement, despite what the doctor says. Because, you know, my interest in myositis started when I did a research period in the Mayo Clinic near Minneapolis. And I have been studying muscle biopsies of patients who did not have weakness but complained about weakness, and they had normal CKs, and we found abnormalities in those muscles. Yeah.
I have a question. Can polymyositis progress to IBM?
I can show you later. Yes, it can.
And also, when I was diagnosed with polymyositis 6 years ago, I only had the EMG and blood tests, and
Yeah.
the CPK was sky high.
Yeah.
But my doctor did not recommend MRI or a muscle biopsy. Should he have? Because now I'm wondering, you know, do I have both, or do I have maybe one more than the other? Can you have both at the same time?
Well, I can show you a patient later in my talk who has exactly the same problem. And I did 2 biopsies, one in the beginning, and then I diagnosed polymyositis. But when he got worse, despite of the treatment, I did a second biopsy and it showed IBM.
Really?
Yeah. Yeah.
See, I'm kind of concerned that maybe I have IBM now, but I'm not even sure about the medications that I take, if they're even working anymore. And I don't know. I haven't tried all of them. I've never been on anything other than prednisone and methotrexate.
Yeah.
Never Rituxan, never IV, IG.
There are other drugs, obviously. Yeah.
Okay,
Yeah.
because
Yeah.
I feel like I don't have the strength anymore and I'm getting weaker.
Yeah.
You know, and
Well, that requires action then.
yes, and I don't think I go to the breast doctor either, so I guess I'm trying to find the right doctor.
Yeah, maybe you should have a second opinion.
Yes.
Yeah, with an expert. Yes.
Are you going to be talking later about findings on muscle biopsy?
Yeah.
Okay.
We'll do. Yeah, yeah, we'll do. Sorry.
I was newly diagnosed with necrotizing,
Yes.
and so my SRP is high, but my CK are normal, so they're kind of confused. I just changed to a rheumatologist because I had a lot of confusion and not really a lot of good plan of care. So I just actually went to see my rheumatologist, my new one, who I love, yesterday. So, do you have any suggestions as far as, I have the symptoms as far as weakness, but they can't, it can't be detected, like, and so I don't know. It's weak to me,
So did I understand correctly that you had normal CK
right, but my SRP.
and SRP is elevated?
Yes.
And did they do a muscle biopsy on you?
My
Okay.
previous one wasn't going to do it. My new one is going to do the muscle biopsy.
Yeah, because that sort of, I mean, the SRP seems to indicate that there is a necrotizing myopathy. But we also, in my clinic, we have seen that some patients have antibodies which do not fit with the entity they are described in, and then a muscle biopsy is really instrumental, you know, to refute or confirm that diagnosis. Well, this is the muscle biopsy procedure. You can have what we call an open muscle biopsy. There they give you a cut 3 to 4 centimeters and then remove the muscle biopsy. And you can also do it with a needle. I must say that I am in favor of this open muscle biopsy, which leaves a small scar, but it gives you ample muscle tissue to do all the tests on.
Excuse me, the needle one is sufficient rather than the open?
It depends.
It depends.
It depends, yeah. Usually in children they do needle muscle biopsy, and usually in adults they do open muscle biopsy, but I know that there are neurologists who only do needle muscle biopsies. I'm a bit afraid that the sample that is taken through the needle is not enough to do all the tests on. And there can be problems with the muscle biopsy, and I'm going to show them to you, although it's really very rare. What is not rare is that if a blind muscle biopsy is taken, then you run the risk that you end up with fatty tissue, because as I showed you on the MRI, gradually the muscle is going to be replaced by fat and only little muscle. And that can be avoided by doing a muscle MRI prior to the muscle biopsy. As you see here, this is the MRI of a patient with severe weakness in inclusion body myositis. And as you can see here, the what we call the quadriceps, the thigh muscle, is nearly completely replaced by fat. So if I wouldn't have done the muscle biopsy and I would have taken a quadriceps muscle biopsy, which is usually the muscle we select for a muscle biopsy, I would have ended up with fat under the microscope. So if you do the MRI from the upper legs, the thighs, and the lower legs, you can easily select a muscle which is a bit affected but not totally replaced by fat. And there's another reason to do muscle imaging. These are the thigh muscles of a patient with dermatomyositis. And you see whitish material here, and that indicates inflammation. So if I ask the surgeon to do here a muscle biopsy, which is particularly affected, the chance that I see a representative diseased piece of muscle under the microscope is bigger than without doing the MRI. We did a study on that, and we found that combining the MRI and the muscle biopsy really helps in improving the diagnosis. So I showed you this, the mislocation of the biopsy, but there can also be a problem on the doctor's or the technician side. The muscle biopsy has to be frozen in order to do some stains, to do some tests, and if if that procedure is not done according to standards, you can get these freezing artifacts, which really hampers the assessment of the muscle biopsy, and the surgeon can do something wrong, and then you end up with a piece of muscle which is not accessible anymore. But as I said, this is very, very rare, and this has become rare because increasingly doctors do MRI prior to the muscle biopsy. There's another reason why the MRI is very helpful in assessing how many muscles there are affected. I told you that usually in dermatomyositis and polymyositis, the inflammation, the whitish material, is here in the thigh muscles and here in the shoulder girdle and upper arm muscles. But you can see here in this patient that there is also inflammation in the lower legs, whereas the patient did not show any weakness. So you can have complaints about weakness, like you. The doctor cannot find any weakness, but when you do a muscle MRI, you can see that there is inflammation in those muscles you complain about. Reading of a muscle biopsy can also be very difficult. Usually we look through the microscope. Sometimes you can also scan the muscle biopsies and then look at the muscle biopsies as a whole and then zoom in and zoom out on the computer. And what we did with a group of specialists, and you see here the specialists from the United States, from the UK, from all sorts of countries throughout Europe. Here is a picture 2012, here in 2014, and we had this get-together in order to try and improve the reading of the muscle biopsy, because we noticed that sometimes people consider a muscle biopsy consistent with dermatomyositis. Other experts said that the same muscle biopsy was consistent with polymyositis. A third one said that it was consistent with necrotizing myopathy. So we thought we really have to sit together and decide on what kind of stains we are going to use and what we really see when we are looking through the microscope, and can we get consensus on that. And the fact that we started in 2012 and came together in 2014, and that it's now 2019, we just published the results of our study, again showing that there is not much of a consensus on all the abnormalities we see under the microscope, means that we have, well, not to start all over again, but we have to do our utmost to improve this, because it's via the muscle biopsy that we make a diagnosis. And it's via the diagnosis that patients are enrolled in clinical trials. And if people are going into clinical trials, we have to be very sure about an accurate diagnosis. Otherwise, it might well be that the results of that trial cannot be relied upon. And recently, and I'm talking about a couple of years, there is the diagnostic utility of auto-antibodies, and we have myositis-specific antibodies like the SRP, and we have myositis-associated antibodies, and those are also antibodies, proteins, which are directed against the skeletal muscle, but very non-specific. Here you see a list of the myositis specific and associated antibodies which are known as yet. In dermatomyositis, we knew that MI2 existed for about 20 years, and the same holds true for JO1 in the anti-synthesis syndrome. But all these dermatomyositis specific antibodies have been identified over the past 10 years, and the same holds true for SRP and HMGCR. It's really a tongue twister. HMGCR in the necrotizing myopathy. And in overlap myositis, you usually only find myositis associated antibodies. A number of years ago in IBM, an antibody was found, anti-CN1A, and everybody was enthusiastic because we thought, now we have the tool in our hands to really diagnose IBM. But the problem is, nothing is specific, and anti-CN1A can also be found in patients with Sjögren's syndrome, for instance, and is only found in about 30 to 50% of the patients with IBM. Yes?
I would like to know, because I have lupus too, I was diagnosed with both,
okay, both.
At the same time. Does lupus myositis, is this part of this?
No, that's not. No, that's not the case.
So how is lupus myositis?
Well, I'm going to show you. That's well known that other autoimmune diseases like lupus, like Sjögren's, like rheumatoid arthritis can be associated with myositis. Yeah.
So myositis could be an effect from lupus?
No. The problem is that we often see that association, that someone has one autoimmune disease and can also get another one. Yeah.
Okay, so that's totally different. The lupus myositis is kind of different from regular myositis, or not really? Is it
well, no, it's and lupus and the myositis.
Okay.
Yeah.
Okay.
Two diseases.
Okay.
Yeah. Yeah.
Yeah, IBM patients that have the antibody, do they progress faster than patients that don't have it? Or
well, some claim that that is the case, but as yet there are only small cohorts. So I am a little bit hesitant to confirm that. Okay. Yeah. Olivier Benveniste, who is also on the medical advisory board, has made this nice cartoon showing that auto-antibodies can fit into one category of myositis. Like all these antibodies can be found in dermatomyositis. I also showed it on the previous slide. But we should realize that only in half of the patients there are antibodies. There are still 50% of the patients who do not have an antibody. Immune-mediated necrotizing myopathy, same story. HMGCR and SRP are found in about 70% of the cases. Still, here it says 20%. We have done a study in which 30% is what we call seronegative. I already mentioned IBM, with only a small percentage of the patients having the antibodies. And then there is the overlap myositis, and Dr. Benveniste is of the opinion that the anti-synthesis syndrome is part of the overlap myositis. Now we do know, and that may well be the case with you with your SRP, that sometimes an antibody, like for instance, I have a patient with MI2 positive antibodies, but she does not have skin abnormalities. I diagnosed her as polymyositis. And the same holds true for a colleague of mine who has a patient with MDA5 positive antibodies, but she does not have skin abnormalities at all. She really had a disease which was quite severe, which presented with breathing difficulty. And a disease you could have seen in necrotizing myopathy. So let's say that the majority of the patients have antibodies like it has been depicted here, but there can be exceptions. I'm going to show you a few, yeah, sure.
What is, I guess, people with the TIF1, do you know what percentage end up getting cancer?
I'm going to discuss
Oh,
that.
okay.
Yeah. I'm going to start with what we call the classic type of dermatomyositis. And those are the patients who usually have these Mi2 antibodies. And you see here, I've shown this picture before, the Gottrin papules, the thickening of the skin. You see here the overgrowth of the cuticles. You see here a rash, that is called the Scholl sign. And you see a rash here under his chin and in his face, obviously. And usually there are both skin abnormalities and muscle weakness, and in general they respond very well to medication. And this is a muscle biopsy. I'm not going to elaborate too much on that, but what you see here is that all the brownish material is inflammation, are inflammatory cells, and all these stains show that there are a different kind of inflammatory cells. And what is very interesting in people with dermatomyositis is that we call this bunch of nerve fibers a vesicle, that at the border of the vesicle there are atrophic fibers, wasted fibers, very small fibers, and they show expression of a protein called MXA, and that is very specific for dermatomyositis. This is a patient with TIF1 gamma dermatomyositis, and you can see that he's suffering from dermatomyositis. I don't have to explain this. He also has some muscle weakness, and I can tell you he is a 30-year pack smoker, and he smokes more than one package a day, and I have screened him for cancer time and again, and he does not have cancer, and I've known him now for 10 years. But you're absolutely right, TIF1 gamma and also the antibody NXP2 are often associated with cancer. So I think that every patient with dermatomyositis has to be screened for cancer, but especially if they have these two antibodies. This is the patient with dermatomyositis and the ulcers, and you see here she has nasty ulcers at the elbows, but also at the fingertips. And in these patients there is usually prominent skin changes, there is arthralgia, joint pain, and usually little muscle weakness. They can complain about muscle weakness, but usually the doctor is not able to find gross muscle weakness. And the CK is often normal. And these patients with MDA5 positive dermatomyositis also often show breathing difficulties because of an inflammation of the lung called interstitial lung disease, ILD. So if we diagnose these patients, we have to perform specific examinations in search of the ILD, the lung disease. This is what I wanted to discuss about dermatomyositis. Now I will jump to anti-synthesis syndrome, and I'm going to show you one of my patients. He was originally from Lebanon, but he emigrated to the Netherlands some 20 years ago, and he was referred at age 37 because he was complaining about fatigue, about muscle pain, and about shortness of breath since a few weeks. He did not complain about muscle weakness, but we found that he had severe muscle weakness. But for him, the shortness of breath was more disheartening and was very disabling. And he underwent a high resolution CT scan, and the radiologist saw all these abnormalities, which is consistent with ILD. He had a very high CK, he had anti-Jo1 antibodies, which perfectly fit into the diagnosis of anti-synthetase syndrome, and also already discussed the chest CT. And this is my patient. He accepts that his pictures are being seen by fellow patients, so he consented in that. Well, you see here that he has a rash. He has pigmentations on his back. He has a heliotrope rash, as is also seen in dermatomyositis, and he has mechanic hands, which you were referring to, which is also a keratosis. And it can be as severe as this, and also on the feet, and then you call it mechanic's feet or hiker's feet. These are the manifestations of anti-synthetase syndrome, and you can see that quite a number of tissues or parts of the body can be affected. Muscle weakness, 100%. I don't know, this might be what we call biased, because this was a cohort of patients seen by a neurologist, and I know that if patients are seen by a rheumatologist or by a pulmonologist, you get other figures, but anyway, this neurologist saw muscle weakness in all his patients. Quite a number of patients also had the lung disease. Joint pain was seen in a substantial number of patients, fever, mechanic hands, and Raynaud phenomenon. You know what Raynaud phenomenon is? That you have white and bluish fingers, which is sensitive to temperature. But these patients with anti-synthetase syndrome, a number of them also showed these abnormalities, which are characteristic of dermatomyositis. So apparently there is some sort of overlap. And on the other hand of the spectrum, there are patients with dermatomyositis who can have mechanic hands. So it can sometimes be difficult to really decide, are we dealing with dermatomyositis here? Are we dealing with anti-synthetase syndrome? Is there also a form of dermatomyositis like anti-synthetase syndrome? And here the muscle biopsy can help. I have shown here the similarities between the skin abnormalities in my anti-synthetase patient and dermatomyositis, and you can easily see for yourself that this patient is obviously much more affected than, as regards the skin, than the other patient. Here you see muscle biopsy in anti-synthetase syndrome and in dermatomyositis. In anti-synthetase syndrome, you can find this nice purple staining, which you usually do not see in patients with dermatomyositis. But even more convincing is that in patients with dermatomyositis, I already showed it before, at the border of these muscle bundles, the vesicles, there are small muscle fibers, but they look pretty normal. Whereas in anti-synthetase syndrome, and I don't know whether it's visible here, there are pink muscle fibers, which means that these muscle fibers are degenerated, and you never see that in dermatomyositis. And also the MXA, which I showed, which is visible here as sort of purple, a purple stain, you never find in patients with anti-synthetase syndrome. So it looks like the muscle biopsy can help you to distinguish between the two diseases. And you see here muscle MRI in patients with anti-synthetase syndrome, and you see that not only the muscle is affected, but also This white rim indicates the fascia, which is the connective tissue part surrounding the muscle to protect the muscle from the environment, and you can also see that in patients with dermatomyositis. And here you see that also the tissue between the skin and the muscle can be affected in dermatomyositis. So many similarities and a few dissimilarities. The overlap or non-specific myositis, also a patient which I'm going to show you, 29-year-old man who complained about myalgia, about stiffness of his muscles, about weakness of his muscles since about 6 months, and he also complained about pain in his joints, arthralgia and a Raynaud phenomena. And later, when I already diagnosed him with myositis, he developed rheumatoid arthritis. So he was quite weak, had a moderately elevated CK, and we did not find any myositis-specific antibodies, but he had a myositis-associated antibodies. And the muscle biopsy showed, again, inflammation between the muscle bundles and around these structures, and those structures are vessels. And this looks quite similar to what we can see in dermatomyositis, but these patients did not have skin abnormalities. So overlap myositis, associated with myositis, associated antibodies in a substantial number of patients, and it can be associated with other connective tissue diseases, like Sjögren, like rheumatoid arthritis, like lupus, I should have mentioned it here, like scleroderma, and like mixed connective tissue disorders.
What exactly is a connective tissue disease? How would you describe that?
Well, the name is a bit confusing, but it looks as if only the connective tissue is affected, but that is not exactly the case. That's how the rheumatologists describe it. But these are what we call the connective tissue disorders, this list of diseases, and I had to add the lupus here.
Okay.
Yeah. And usually myositis is not considered to be a connective tissue disorder.
It's not?
No. But as I said before, if you have these diseases, you can develop myositis, and alternatively, you can have myositis and develop another connective tissue disease.
Or you can just have myositis, you don't have to have
Absolutely,
lupus or anything else.
absolutely. Or you can have a connective tissue disorder and not develop myositis.
So if I wanted to go for second opinion, and I already go to a rheumatologist, and I know that neurologists treat IBM. So would I go to a neurologist or another rheumatologist to see if I actually do have poly, or if it's become an IBM, let's say?
Well, it's difficult for me to say. I'm a neurologist.
You're a neurologist.
But I know that rheumatologists, I mean, the experts know how to distinguish a myositis from IBM, really. You have quite a number of experts here, rheumatologists. Why don't you see one of them and ask them? Dr. Agarwal, for instance.
You mean through Mayo Clinic?
No, I mean, you drink a cup of coffee, have a cup of coffee with him and discuss it.
Okay.
He's very open for questions like that. That's why we are here. And then necrotizing autoimmune myopathy. In short, necrotizing myopathy, again a patient, a lady who originally was born and raised in Portugal, and she and her husband came to the Netherlands, and she was referred because she complained about weakness in the arms and legs since about 4 months, and also difficulty with swallowing. And I asked her whether she has had statins, and I'll come back to that in a while. And she said yes, but she stopped them 3 years previously, prior to the referral. Indeed, she had weakness of her arms and legs, quite a high CK, and her HMGCR antibodies were positive. This is her MRI, and I did a muscle biopsy, and it showed only degenerating muscle fibers, these pink guys, but no inflammation whatsoever. So I was sure that she's having a myositis, but because of the lack of the inflammation and because of these antibodies, she was diagnosed as necrotizing myopathy. These antibodies were first found by Dr. Memon and his group, and he's also here, in patients who used statin, but later they also found these antibodies in patients who never had statin in their lives. Anti-SRP is another antibody, and as I mentioned before, there is quite a number of patients who do not have any antibody at all. Here too, there can be an association with connective tissue disease. A minority of the patients also has lung disease, and there is a claim by the French group that people with HMCCR positive necrotizing myopathy might develop cancer. Well, anyway, it has not been confirmed by others, but in the meantime, if I diagnose a patient with HMCCR necrotizing myopathy, I'm going to do a search for cancer. It can be a very, very severe disease with a variable onset. Sometimes people develop their symptoms in about 4 weeks, but sometimes it takes more than 10 years. And you can imagine that it then becomes very difficult to distinguish this myositis from other muscle diseases like hereditary muscle diseases. Children can also be affected, and weakness can be so severe that also the neck extensors are involved, and that leads to this dropped head. Swallowing difficulty can be seen, and sometimes also respiratory insufficiency. And I put a question mark here because it's not sure that the heart muscle is also affected, but there are some case reports. And then inclusion body myositis, I already showed you some of the pictures of these patients, and I'd like to focus on the muscle biopsy, which shows that this muscle is surrounded and a bit invaded by inflammatory cells, and you also see this whitish material, and that means that there are vacuoles, holes in the muscle. And not too long ago, the doctors claimed that you needed to have those holes together with the inflammation to make a diagnosis of IBM, and I'm going to show you that that has changed. Well, this is a patient in whom I had quite some difficulty in establishing a diagnosis. He was referred at the age of 65. He was complaining about swallowing difficulty, especially solid food. He needed to take small bites. Sometimes he coughed while he was eating, and sometimes also the food came through the nose. No problems with drinking, and over the past year he lost about 7 kilos. He first was referred to an ENT specialist and subsequently to a gastroenterologist, and they did tests on him. But I'm going to show you the patient. He is subtitled. I don't have his voice, but you couldn't understand him anyway because he speaks Dutch, but it is subtitled. And here he explains what he sees as swallowing problems. Can you also see it in the back? Okay. It gets worse when he's nervous, he told me. Yeah, and he has the feeling that the food won't drop. And later he also developed difficulty with swallowing liquids. But it started with solid food. Well, ask him, why did you wait for a year to see a doctor? And he said, well, you know, I thought maybe it, you know, resolves just like that. Well, he didn't have any other problems, no weakness of his legs or his arms, no shortness of breath, nothing of that kind. And this shows you a video fluoroscopy. You can see here a video recording of food going down. First, a normal one. And you see here the bolus going down. And now an abnormal one. And this is the wrong way. And then it, you know, you see here that trickle. It's in the windpipe. So you can imagine that if that happens, the patient starts coughing. When the gastroenterologist saw this, he referred the patient to us. And he was treated by the ENT specialist for about, with Botox, and that was effective for about a year. And then he started having swallowing difficulty again. And in the meantime, I was following him. And at some point, he complained about fatigue in the legs. And he told me, it feels like I have walked the marathon. And he did not do any exercise at all. So I examined him. I did not find muscle weakness, but he was complaining about muscle weakness. So I'm sure that he was weak. And I did an MRI of his leg muscles, did not show any abnormality. And despite that, I did a muscle biopsy, and that showed that he had inflammatory cells not only surrounding the muscle fibers, but also invading the muscle fiber. He did not have vacuoles, but I was sure to make a diagnosis of IBM in this patient, which startled him in a way. On the other hand, he was relieved that after so many years, we have been able to come forward with a diagnosis. I'll come back to that later, the muscle biopsy. I told you that I was going to present a case, maybe like you, I don't know. 50-year-old man, and he was a nurse in the theater of the surgeon. So he was really doing heavy work. And he complained about difficulty getting up the stairs. He indeed had muscle weakness. He had a moderately elevated CK, and I did a muscle biopsy, and I diagnosed him with polymyositis. And I started to treat him with prednisone and MTX, and he did quite well for a number of years. But there were relapses when I tried to taper the prednisone and taper the MTX, because we all know about the complications, the side effects of prednisone. He had a relapse, he got worse. And then I increased the dosage, but it was not very effective. And after about 9 years, he really had developed progressive muscle weakness. And he had a very, very severe paresis of his hip flexors. So I said to him, I'm not sure about the diagnosis polymyositis anymore. Shall we do another muscle biopsy? And I did a muscle biopsy, and this was totally compatible with the diagnosis of IBM. And whether he now has had polymyositis, which developed into IBM, or whether I misdiagnosed him in the beginning, I really don't know. Yeah.
My doctors are trying to tell me, because the only way they can tell if my disease progresses is by muscle biopsies.
Yeah.
I have a few. So they tell me though that it's kind of patchy, like muscles are
That's right.
patchy, so they don't like know if they missed.
Well, that's the reason for the MRI, because you see the patches of inflammation, and if the surgeon takes or puts a needle in there or takes a piece of muscle biopsy, it increases the chance that you really have a diseased piece of muscle.
So that's what they mean by patchy.
Yeah.
'Cause my
Yeah.
mom got a muscle biopsy also, but she refused the MRI. So that's why
Yeah, if she suffers from claustrophobia, it's very difficult. Yeah. But they can give you some sedation.
Did this
Currently.
Did this patient have an MRI then, when he first came in and was diagnosed with poly?
No, because that's quite a long time ago, and at that time we did not have an MRI.
Oh, okay. Because
Yeah.
I didn't either.
Yeah.
And that's why it wasn't recommended
Yeah.
at the time. But I feel like what I'm taking is not really helping me, and I'm wondering if there's another drug that I should be taking.
Well, as I said, I think that the doctor and you should start from scratch again, and have a look at the right diagnostic procedures. And I mean, you know, this patient was working in healthcare, but on the other hand, I could convince him that I was no longer sure of the diagnosis polymyositis and not sure about continuing the prednisone and the methotrexate, because as soon as we made this diagnosis, we had to stop that medication. And it was really worth it taking this second muscle biopsy, because now we were sure about the diagnosis. Yeah. Well, as I said, when the first time that IBM was diagnosed, was recognized as a separate disease entity, so that was in the early 70s, the researchers said you need to have the inflammation around the muscles, and you need to have the vacuoles, the holes in the muscle. But increasingly, we and others saw that there were patients who had the IBM phenotype and had these inflammatory cells around the muscle fibers, but no vacuoles. And now we know that the rimmed vacuoles, as we call them, are not a prerequisite for the diagnosis of IBM. But there should be a characteristic clinical phenotype. This is nowadays the classification. Dermatomyositis, as I mentioned, with or without muscle weakness, overlap myositis, necrotizing myopathy, anti-synthesis syndrome, and together we call this polymyositis and IBM. And here you again see the various muscle biopsies. They really differ from each other. And at the end of my presentation, I want to show that sometimes it's very difficult to distinguish a myositis from a hereditary muscle biopsy. For instance, this was a cohort from China, and these patients had necrotizing myopathy with anti-SRP, but you see here on the MRI that the hamstrings have completely been replaced by fat, and that's usually what we see in hereditary myopathies. So in these patients, it can be difficult, and then you have to rely on the antibodies. And oh, that's a pity that it comes up now, but what I wanted to show is that this was a slide which was provided by a colleague of mine, a neuropathologist, and here you see all these inflammatory cells, but he usually does another routine stain, the dystrophin stain, which is abnormal in patients with muscular dystrophy. This was the patient the muscle biopsy was done on, and he was not suffering from a myositis, but he was suffering from a muscular dystrophy, Becker muscular dystrophy, and we know that in that particular kind of muscular dystrophy there can be lots of inflammation. So that can be confusing. This is unfortunately also a patient of mine whom we diagnosed with myositis. We treated her with high dosages of prednisone, and she was left with these awful striae, as you can see here. She didn't improve on high dosage of prednisone, and later she was diagnosed with a specific form of muscular dystrophy, which at that time was not known. And sometimes it can be very difficult to diagnose a myositis. This little girl was flown from the Netherlands Antilles to the Netherlands to establish a diagnosis. And she had a 2-year history of progressive muscle weakness. You can see that she has difficulty getting up from the floor, and she had frequent falls, and none, her parents and her siblings were not affected. Her CK was normal. So the doctors in the Netherlands and Tilly said, why don't you do a muscle biopsy? Because it's very important to have a diagnosis. And the child neurologist in my hospital said, I'm sure that we are dealing with some kind of muscular dystrophy. And this is what the pathologist and I saw when we looked through the microscope. Lots of inflammation. And in the meantime, you may have recognized these are the small muscle fibers at the border of the vesicles. So this patient had dermatomyositis. And we asked the child neurologist and the dermatologist to get back to the patient. And they were a little bit embarrassed because this is what they saw. Old Gottron papules on the hands and on the knees, and overgrowth of the cuticles, and calcifications in the knee joints. And that all fits nicely in a patient in a diagnosis of dermatomyositis. She was treated and she was completely resolved, the muscle weakness. Yes?
Are you talking to me?
Yeah. Now you raise your hand.
I did.
So I approach you.
This
Yeah.
is kind of off the subject, but it has to do with IBM.
Yeah.
Do you know what is the significance of upregulated MHC class 1 in
Yeah, that is one of the markers, I must say, to establish a diagnosis of IBM on. Yeah, it's not the only one.
But no, I know. But what makes it upregulated? Do they know?
No, they don't know.
Okay.
No.
So that's one of the
No.
unknowns.
No.
The other thing is what percentage of IBM patients develop respiratory problems?
Like that.
Unknown?
Yeah. No, it's known. A very, very, very small percentage. But what can happen in IBM? Oh, you are one of those. Yeah, yeah. What can happen in IBM is that because of the swallowing difficulty, patient can get pneumonia, and in that regard have shortness of breath. Yeah, but you really have a decreased lung function.
Yeah.
Okay. Yeah.
Just recently diagnosed with chronic neuromuscular respiratory failure.
Oh, failure.
That seems a little
Yeah.
extreme to me, but
Yeah.
I'm not sure that's, anyway,
Yeah.
I'm not sure I trust the pulmonologist on this,
Yeah.
but I do have restrictive lung disease,
Yeah.
and I do have air trapping,
Yeah.
and it is one of my major problems.
Yeah.
It's worse than the muscle weakness. I can get up and down out of the chair all day,
Yeah.
but breathing and dysphagia are major.
And your muscle biopsy indicated an IBM.
My muscle biopsy indicated IBM, and also the
CNA, yeah.
C1N.
Yeah, but I told you, I mean, that's not always reliable, and or either.
T-cell LGL leukemia.
Okay. Oh, okay.
So-
Okay. Yeah, that adds up. Yeah. Oh,
So, anyway,
then you're one of the unlucky ones. Yeah. Yeah. I'm almost there. This was a girl, and her mother was an ophthalmologist, was a doctor, so she was not crazy. But despite that, it took about 1 year of her daughter, complaining about muscle weakness, having difficulty getting up from the floor, before she was referred to us. And I really, was startled to see her, because she was very severely affected. She had a very high CK. At that time we did a muscle CT because we did not have an MRI, and it did not show any abnormalities. And I thought, are we dealing with a muscular dystrophy here or with myositis? And first we saw this, and then the pathologist made some other cuts, and we saw that she had cell infiltration, and she was treated with prednisone and methotrexate, and it is not off medication, is doing much, much better. Well, this is my last slide. I hope that I have shown you that you have to consider all the diagnostic procedures. Because otherwise you get the six blind men and the elephant metaphor. That someone thinks this is a snake, this is a tree. So you cannot settle for a diagnosis with only the antibodies, or only the muscle biopsy, or only EMG. You have to consider to do them all, yes?
Do you think that diagnostic best practices in the US and the EU are aligned?
I think so, yeah. Because, you know, we collaborate across the ocean, and we exchange our experience. So I really think that is the case, yeah.
I'm in research, I would agree.
Oh, okay, that's nice. Yeah, yeah. There might be an exception for patients with the characteristic features of dermatomyositis. I could imagine that if there is characteristic dermatomyositis, that you don't do a muscle biopsy anymore, especially now we have the antibodies. But all the other entities of myositis really require a muscle biopsy. You had a question?
Yes. So I never had a muscle biopsy. I had a skin biopsy.
Yeah, that is also sufficient.
Could a skin biopsy, could it look the same as like for could that, you can have a rash with the
Anti-synthesis syndrome, ASS, just like that. We don't have that experience. It hasn't been examined, hasn't been a subject of research.
Because I'm seeing stuff that looks really similar.
Yeah.
And I'm wondering then if I never had an MRI, never had a muscle biopsy.
But you have antibodies?
TIF1.
TIF1. Well, that is very unusual in dermatomyositis, but as I said, you can have the DM-like anti-synthesis syndrome, and it can be the other way around. So there is really some overlap in those two. And only recently we know that there are dermatomyositis-like abnormalities in ASS. Yeah. So you might ask your doctor to get, oh, it's Mayo.
Well, I'm going to get back to Mayo.
Okay. I think that is, oh yeah, this is what I wanted to show the last slide. Thank you. Yeah, you have a question.
Okay, so I have the anti-MJ NXP2 overlapping of scleroderma and calcinosis disease. I think you talked about the knees and
the overlap myositis, yeah.
Overlapping. And we also discussed about the gap in between to try to make sure that you wasn't misdiagnosing. So how many years did it take for you to do another biopsy? Because of the
15 years?
Okay, because I've been dealing with it since 2007 and this present time today.
2007?
Since 2007.
Yeah.
They did a polymyositis, but we did a deltoid muscle biopsy.
Well, actually, 2000 in IBM is quite unusual. Usually in IBM it's below 1000.
Okay, so I have dermatomyositis.
You have dermatomyositis, okay, yeah. But it can be possible. As I said, it can be very high, but it can also be normal. Yeah.
Because my CK level at that time when they diagnosed me when they did a deltoid muscle biopsy was 8,000.
Oh wow.
So it's 8,000.
Yeah.
So the MJ is the juvenile.
MJ?
The anti-MJ is the.
I'm not sure.
The NXP2 is.
NXP2 is dermatomyositis, that's right.
What is that? Is that the nuclear matrix protein?
Yeah, that's right.
Okay.
Yeah.
Because I know you was saying that you screen for cancer. So
Yeah.
the CBC.
Yeah. Well, I don't know at what age did you develop dermatomyositis?
26 years.
26, okay, yeah. Because there can be kids with NXP2 as well and TIF1 gamma, and they never develop cancer.
But that's what I was trying to figure out. Was it juvenile myositis?
Yeah, but juvenile means below 18.
Okay.
Yeah. Okay, wonderful to have you with me, and thank you for raising all those interesting and for you very important questions, and for me as well, because I learned a lot.